it's Dr. Narala Jacobi. If you treat SIBO in your clinic and are interested in the causes that entrench chronic or relapsing SIBO, you're invited to my live and online masterclass on preventing SIBO relapse on March 9th as part of the Bioceuticals Clinical Mastery series. If you want to learn the evidence-based approach I use to manage this condition, reserve your place at bioceuticals.com.au.
Hi, and welcome to FX Medicine, where we bring you the latest in evidence-based, integrative, functional, and complementary medicine. I'm Emma Sutherland, and joining us on the line today to discuss cultivating a healthy genitourinary microbiome is naturopath, acupuncturist, and academic Moira Bradfield Strydom. Welcome back to FX Medicine, Moira.
Oh, it's great to be back. Thank you for having me.
It's a pleasure. Now, unlike the gut microbiome, a healthy vaginal microbiome is characterised by low diversity of microorganisms, combined with lactobacilli dominance, as lactobacilli are essential for the production of lactic acid, which maintains optimal pH of around 4.0. Now, Moira, you've been a frequent guest on the show, and thank you for taking time out to join us again. For those listeners who might not be familiar with your work, can you tell us a little bit about your background and what led you to this area of interest?
Yeah, so been a naturopath for a little while now. I'm coming up in 21 years, and I don't know if I had a choice to be anything but a naturopath. That's, I think, apart from wanting to be a ballerina at one stage, that's all I wanted to be was a naturopath from very early on. So I went into study straight from high school.
Wow.
And then straight from university into private practice at that point.
Yeah, incredible. But when you were young, what made you interested in becoming a naturopath?
Gosh, many things, I guess. I mean, I grew up in beautiful Hobart in Tasmania, and nature is a big part of being a Tasmanian. And so I suspect that had a huge influence on me. And also in terms of my mother was very big on not always going for more mainstream solutions and looking at how we could possibly support ourselves in other ways. So there was definitely influences in that. And through high school, I did, interesting things, like did some work experience in Gould's apothecary down there. And I also went into health food shops and sat with some naturopaths, and at the time was seeing a Chinese herbalist. So lots of different things like that sort of cemented that that's what I wanted to do. And just really being inspired by looking for alternate solutions. What was, what else could we be doing? There's got to be other answers. So, yeah, it's sort of something I haven't reflected on because, as I said, I don't know if I ever wanted to be anything else. And even, at the early stages of then going and applying to go to university and get that degree, obviously I applied for other things as well. But as soon as I found out that I'd got into naturopathy, I unenrolled because I was in the process of enrolling to be a marine biologist when I got my acceptance letter. So, it was, top of the pick for me to go down that path and really immerse myself in more natural and holistic solutions for healthcare.
Yeah, and obviously you have a very curious mind, because I think naturopathy is all about being curious about possibilities and other ways of doing things and other ways of seeing things.
Yeah, I think so. I mean, it's interesting as I've aged to understand how my mind works more. And there's certainly some very atypical things I've noticed about myself, but I do love a good puzzle. And I love to think expansively and then to be able to contract and expand on different parts, which I think is a really big part of understanding systemic healthcare and looking at it and, looking at an individual area, which is often why somebody presents to you, but being able to integrate that and understand how that functions as a whole as well. So my brain really likes that sort of thought process.
It certainly is a challenge at times, and you're right, the puzzle is a great analogy for patients.
Yeah.
Now, I want to talk to you about, your specialty in the area of genitourinary health. Why did you decide to head down that path specifically?
Yeah, it sort of presented itself to me. It's not something that I went seeking at all. I had been in private general practice for, maybe 15 years at that point, and had started to see a run of clients in clinic that had unexplainable discharge or recurrent infections. And I found that the approach that I was utilising was not working.
Okay.
And so when I went to dig in and think about why, what I realised that there was a whole area of health that I really didn't have a knowledge base in. And so I threw myself into that and realised as that opened up that it was something that I was really interested in. And, up until that, I had no, interest in specialising or having a special interest in anything. I was a general clinician, and that was good.
Yeah.
But this area really ignited my fire, and I think because there are, obviously I'm a female, and there are aspects of my own health journey that resonated and made sense as I dug into that literature, and then I also started to realise that because it wasn't something that we talked about or that we learned about in great detail, that my role as an educator, because I had been in education for a long time at that point, was to also, how can I take this to other practitioners, because this is a really important and overlooked part of health that a huge percentage of our, potential clients or patients actually have issues with, and we're not even digging into it, or we're too shy to ask those questions.
Yeah, and I would definitely say that we are undereducated in this space when we go through our training, and it is something in clinical practice that patients will come back again and again with the same symptoms. And, we're going to deep dive into all of this, but as a practitioner, it can be very frustrating when you feel your knowledge is not sufficient enough to really help these patients get better results.
Yeah, definitely. I mean, I think for me, the big realisation is that most of it is not an infection.
Yeah.
was a huge part of it, So why are we addressing it that way and throwing lots of antimicrobials at it instead of thinking about it in a restorative way?
Yeah, it's a very one-dimensional way of thinking about it. You're right.
Yeah.
Now, you're also doing your PhD. So tell us what you're working on. I admire anyone who takes on a PhD.
Yeah, it's been quite a journey, and it's coming to the end of it now. And I'm working in the area of recurrent thrush because of all of the things that I was dealing with in clinic. That one has the least amount of answers, and it certainly is frustrating to see people that have had, 10, 15 years of symptoms that come back on a monthly basis, and to have had, a whole barrage of antifungal medications thrown at them, both holistically and pharmaceutically, only to have those symptoms return. So I thought, gosh, what can I do in this space? This is the biggest area I think that troubles me, that I want more answers to, that I think we need to understand better. And so I ended up, from the genesis of deciding that I wanted to do further study, in meeting my supervisor, who also wanted to do some work with some specific compounds in terms of recurrent thrush from her background. Meeting, and it was very, it was just one of those things that all the stars aligned, and I ended up going into PhD studies looking at recurrent thrush. So we're looking at a number of different factors, and certainly doing a PhD through a pandemic has meant we've had to pivot numerous times in how we approach the work. But we're running a clinical trial, seeing if we can reduce the severity and frequency of thrush flares in people who experience recurrent vulvovaginal candidiasis. And we're using an intravaginal application to do that. Okay. And then there's been some side projects that have come out of that as well, because one of the papers that we have had published is around the pharmaceutical management of recurrent vulvovaginal candidiasis in Australian guidelines. And what we found was that the treatment, is successful whilst people are on it, but there's a really high relapse rate associated with recurrent thrush once you've stopped some of those longer-term azole therapies. And there's also, a huge, like many other, I think, female health conditions, there's also delays to diagnosis, there's mismanagement, there are people that feel like they've not been heard. So we've also been involved in some semi-structured interviews looking at qualitative data to talk to people that have recurrent thrush as a diagnosis and what they've been experiencing. And what's come through for them. And there's a lot of, uncertainty and feeling like they've just not been listened to or supported in their journey.
Yeah.
And then the third project that we're running is a microbiome study. So we're looking at vaginal and gastrointestinal microbiome of people that have recurrent thrush who have used oral fluconazole therapy, either for maintenance, so longer term periods, or 4 times or more in the last 12 months, and comparing that to people who are essentially healthy controls to see if there are differences in the microbiome, because there's no long-term data on what the impacts of these pharmaceuticals are on those microbiome sides. And there's also some disparities when we look at microbiome research between what constitutes healthy or whether there are bacterial shifts associated with these, primarily what we believe are fungal conditions. And there's not necessarily any data on the gut microbiome, people that have recurrent thrush either, despite, long-held beliefs that candida is in the gut and that's why it ends up in the vagina, etc. So we were looking at statistics of carriage as well for candida on a gut level, as well as obviously microbiome trends in the gut associated there.
I think I cannot wait for that your research to be released. I'm already incredibly fascinated. And I think that recurrent thrush, to me, it's a little bit like endometriosis in as far as patients come in and they feel that they haven't been heard, they've been misdiagnosed, and they're frustrated as anything with this recurrent set of symptoms that they're experiencing. So, anything that sheds light in this space is going to make profound impacts on the experience these women have.
Yeah, I hope so, because they deserve it. And, there's certainly aspects of recurrent thrush that makes it look like more of a syndrome than an infection, but you see it being treated as, episodic infections rather than looking at a whole basis of it. So, there's certainly factors associated with things like allergy. There are genetic components that they're identified. There are certainly hormonal risk points as well. And, those things are not often acknowledged or explained to people. And we don't necessarily have the interventions, particularly in a medication sense, that can come in and even impact those things. So, there's lots of gaps in the understanding of what constitutes it, which also leads into why it's often overlooked as a diagnosis, because sometimes people have symptoms without a culturable microbe, and that's part of that diagnostic criterion as well. And sometimes people don't have the full extent of symptoms. They can have, an ongoing irritation or an erythema, but they don't have a discharge, or they have a discharge, but they don't have those other classic inflammatory signs. And that all still fits under the banner of recurrent or chronic, even vulvovaginal candidiasis, because there's a spectrum of severity that goes with recurrent thrush as well.
With this whole subject being such a pain point, literally, for so many women, why do you think that it hasn't been identified before as an important area of study? I mean, it just kind of baffles me in a way that it hasn't been highlighted before now.
Yeah, I mean, it is baffling, and there's certainly some heroes working in that space and have been in that space for a long time, doing research and doing, looking at case studies and things like that over long periods of time. So it is there, but I think it's chipping away in the background. And from a clinical practice perspective, when we look at mainstream medicine, a lot of these very recurrent pictures are not something that are seen in some aspects of, hospital-based gynecology, for example. So it's more of a private practice point. And so it's about what is on the radar and what the burden of that is as well. And now we're only just obviously coming to this new understanding of what microbiome health is. And we have a lot more information on bacterial microbiome health than we do fungal microbiome health, and that fits into that. And there are various factors and obstacles in understanding the fungal microbiome in terms of just testing and databases and all of those other things. So it's a journey, and it's improving every year. I see more and more, and we get really excited about how many people are interested in this, and we're seeing more startups, who are interested in it. But it's one of those things, I guess. It still falls under that banner of, of women's health and there are acknowledged areas in that. And from a research perspective, and now from running a clinical trial, there's a lot of obstacles when you're dealing with people that have menstrual cycles and you're dealing with vaginal health, because, we're timing an intervention with somebody's menstrual cycle, and you've got to wait for it to come around, and then you've got to recruit them in at the right time, and then obviously things happen like sex and morning after pills, etc. So there's lots of possible reasons why it's too hard.
Yeah, I can. A lot of research has been done on male rodents and males for a reason, because, as women, we have these fluctuating hormones and all these other things that can happen. So I can just imagine the logistics are massive.
Yeah, totally. And particularly when you're looking at longer term studies as well, because, a lot can happen over 9 months. Of using an intervention or, following people. So it becomes really problematic. And when you've got something that's much more predictable and consistent to research, and that's generally safer, I think, in terms of that perspective. But it's also because it's probably not talked about. So the severity of it is not that well acknowledged, because even the people that have it are reluctant to talk about it and to talk about its impacts because of the various levels of taboo associated with it.
Yeah, it definitely is a topic that you have to have some very direct questions with when you're working with women, so that you get the answers that you need. Now, I'd really love to discuss how estrogen affects the vaginal microbiome. I mean, clinically, we see this at different points of the menstrual cycle, with patients more likely to get outbreaks of thrush during their period, and then less likely to get outbreaks around ovulation. But how does estrogen fit into that and the susceptibility for infections?
Yeah, so estrogen is probably one of the most important hormones to consider when we're talking about vaginal microbiome health. And its relationship is to the cellular health in terms of how many, or what the density of epithelial cells are within the vaginal space, and therefore the expression of glycogen, which is the fuel that via some amylases becomes the fuel for those lactobacillus bacteria. So their survival is dependent upon good levels of estrogen, good cell expression of glycogen. So when we look at lactobacillus or lactobacilli microbes, we talk about them in as a very overarching concept as being associated with vaginal health. And as an area, as a microbiome, we have less diversity because we tend to see dominance of lactobacillus and some low-level microbes, and that's good, and that's eubiosis as far as the vagina is concerned for most people. There are exceptions. So this estrogen rhythm that we have, we see as being really important to correlate to lactobacillus. So when we have stages of life or even stages of the menstrual cycle where estrogen may be lower, then theoretically lactobacillus may be challenged, or their numbers may not be as robust, or they may not be, fed as well, essentially. And so infection risk for bacteria becomes higher, or dysbiosis risk for bacteria becomes higher at those stages. So when we look at premenstrual, menstruation, and then early, obviously until estrogen starts to peak again, those time points become more common for people, for example, who have bacterial vaginosis, because the estrogen and the lactobacillus equation, when we have BV or bacterial vaginosis, that is characterized by a loss of lactobacillus and an overgrowth of facultative anaerobic microbes, so things like Gardnerella, for example. So we can think about estrogen over a lifespan where, we have pre-puberty, then the microbiome will be different and not as lactobacillus dominated. We move into more estrogen dominant stages of life, pregnancy, menstruation, so there'd be more lactobacillus overall. And then as we move towards perimenopause and menopause, we start to see that relationship decline, because the estrogen declines and the lactobacillus are not as prevalent, or they start to disappear, and the microbiome becomes more diverse. So we have these sort of macro, micro situations. We have stage of life journeys, and then we have a menstrual cycle itself. So understanding that rhythm of hormones helps us to understand possible fluctuations that can occur, particularly in people that already have symptoms, because their disorder becomes more pronounced at different stages, because there usually are some sort of hormonal rhythm issues as well for those people.
Yeah, and I think a great point here is discussing those very facts with patients, and so they can really understand why their body is more susceptible at certain points in their lifespan or their menstrual cycle, and they can really become more empowered in that rather than feeling like they're at the whim of these symptoms randomly.
Oh, totally. And I mean, symptom tracking is one of the most important things you can do for people to recognise their own rhythms and risk points. It helps you to, identify what could be going on. It helps you to also apply any prophylactic therapy if you're looking to, stop a cycle of recurrency. You start by addressing it right before or in that time period where they're moving into a riskier period for them. Understanding those patterns, and they previously may never have been aware of those patterns, can really help to empower them, because they might know, it's safer to have sex at this time of the month because, I generally don't get symptoms then. And it's only when I start to see that rhythm changing, either less estrogen in the case of things like bacterial vaginosis or aerobic vaginitis, or more estrogen, which can become a fuel for fungal microbes. So with thrush, we see ovulation through to mid-luteal sort of being a riskier time point, where it's actually not just the estrogen, but it's the relationship between the estrogen and the progesterone, and what that does in that situation to influence, or create an environment that's more favourable to some of those more fungal-based microbes.
Right. Well, talking about microbes, let's dive in. I would love you to tell us a little bit about Lactobacilli crispatus. So a 2020 review stated it was widely regarded as the best marker for vaginal microbiome health due to its proficiency in producing lactic acid and hydrogen peroxide. But can you tell us a little bit more about this bacteria?
Yeah, I mean, it is one of those ones that people tend to focus in on as being the one they have to have, it is an important microbe, and it is probably the king of lactic acid and hydrogen peroxide production, which means it's environmental control in terms of pH and inhibition of other opportunistic microbes is much better than some of the other Lactobacilli species that can inhabit that space. But when we look at it, not everybody will be able to hold Lactobacillus crispatus in their microbiome, nor should they be able to, because we also know with microbiomes that there are, vaginal microbiomes, that there are different categories, I guess. They're called community state types. So they're different profiles that people can fit into, and they refer to the most dominant type of lactobacillus that they might have, or a lack of lactobacillus dominance for some of those community state types. So we seem to have a lot of research that's focusing in on Lactobacillus crispatus, both in supplemental form and in general in terms of native carriage of this as a species, associated with different health traits like being able to conceive, for example, or being less likely to have a fungal infection or less likely to have bacterial vaginosis. But it's not everything, I think, because there are also some research that suggests some Lactobacillus crispatus may be problematic, or that too much of it is also a problem, because we see this significant lack then for shifting of diversity in the other direction. And so there's a condition called cytolytic vaginosis, where some of the newer research coming through suggests that it may be a Lactobacillus crispatus overgrowth.
Wow.
And there are different reasons why people may end up with a lot of this. Like, it can be, they believe it's hereditary, in that you can have crispatus coming through generations of people from obviously your mother and your grandmother, etc. And that's a really strong and robust microbiome. But sometimes we see this microbe turn up in excess because there's been over-treatment, or there's been a loss of some of those other more diversifying microbes within the microbiome. So it's interesting, and I think it's going to be a watch this space, because we have some conflicting information about crispatus in both, general health and then special subsets as well of research in terms of fertility, or with the work we're doing in terms of recurrent thrush, for example. Crispatus is something that we're focusing in on for that very reason, in terms of over-treatment and is that moving through and becoming more of a cytolytic type picture.
Yeah, it's just so fascinating, but it also it once again reinforces that point that it is about balance when it comes to any kind of microbiome. I was heading into this interview, I was reading a 2019 study on around 300 women that showed an increased rate of IVF success if they had more than 60% Lactobacillus crispatus. But as you say, it's not always a good thing to have too much. But what do you think is the actual mechanism here of how that impacts IVF success?
Yeah, there's been a few studies around crispatus and IVF and what's on the catheter tip, for example, when they do, the embryo transfer. And the Lactobacillus crispatus situation is very interesting because I think when we look at one of those research papers, it suggests that if you actually have higher amounts, that there's a less chance of implantation, whereas less than 60 and lactobacillus dominance is actually conducive to achieving pregnancy. So, and I think when we look at the type of people who are in need of assisted reproductive technologies, that there's a whole array of different health conditions that have led them there.
Yeah.
And with that comes a history as well of treatment and antimicrobial use and all of these other things that we need to consider in addition to hormonal issues. So it's an interesting thing to evaluate. And I was looking at that 2019 study and sort of trying to understand, because they had this, almost opposing thing where they were talking about Lactobacillus iners also being associated with pregnancy outcomes. And iners is another one of those things that we have an opinion on it, that it's a lactobacillus and therefore it has some benefit, but it tends to show up when there's transitioning going on, or it's a bit of a rescuer. So we don't know if it's actually good or bad or what its deal is, and it's all of those things depending upon the strain specificity of it. Yeah. But the overall, when we look at lactobacillus dominance, it doesn't necessarily matter which microbe it is, although there are also some other ones that are less, like ginseng. Their mechanism is, that the ability of them to produce lactic acid and hydrogen peroxide is about environmental immune control, that their production of metabolites and bacteriocins are about inhibition of pathogens and therefore decrease of inflammation within that area. So all of these things are conducive, obviously, to successful pregnancy and not immune activation at that point as well. Overall, a healthy microbiome, as I said, largely in this space is lactobacillus dominant and pH regulated, etc. But I suspect when we look at that opposing result where they were talking about over 60% lactobacillus crispatus having a slight reduction in pregnancy outcome, then it may also be because we know, looking at pH and what role that can play around pregnancy and that natural fluctuation of pH around different points of the menstrual cycle for obviously helping, sperm and egg meet each other, etc. Yeah. So there's lots of things I think that we don't fully understand, and sometimes focusing in on these singular microbes can mean we miss the bigger picture. But it is nice, those sort of studies that do the whole microbiome profile, because we get to see these sort of traits and shifts, and it gives us this understanding that obviously we don't want people, if they're already in that situation and having issues with reproduction, that we don't want them to have other types of anaerobes dominating their microbiome, and that generally they need to have lactobacillus at a good amount to have that stability and to have that healthy microbiome to be able to enhance their outcomes.
Yeah, and looking at endometrial receptivity and the microbiome, is there a role there for dysbiosis and inflammatory changes in driving progesterone resistance? I mean, I truly realise we're just at the tip of the iceberg on all of this. Over the next few years, we're going to see so much more information coming through. But what are your thoughts on the microbiome and the endometrial receptivity side of things?
Yeah, it's a great question. And I mean, it's not something I've spent a lot of time thinking about because my space is not necessarily fertility driven all the time.
Yeah.
But I do think that when we look at the endometrium and what we know on a microbiome level of both the endometrial microbiome and the vaginal microbiome is that they are connected in an upstream from the vagina to the endometrium, and that they have common traits amongst them, and that we certainly have information in situations like endometriosis, for example, where there are microbiome profiles of the endometrium that are inflammatory and driven by microbes that are not conducive as well to implantation and fertility. So within that, when we look at what we know about endometrial receptivity and progesterone resistance, that there are these common markers of inflammatory changes and of T cell reactions, and the suggestion that that sort of resistance is aligned with hallmarks of some endometriosis pictures as well. I think that the microbiome is definitely implicated. I just don't think we have the details of how exactly at this point. And that even the research on the endometrial microbiome talking about its role in fertility is still in its infancy. But I mean, it's certainly going to be an interesting space to watch. And as it comes to light, I'm looking to be both excited and amazed, and also, I thought so.
I'm sure that's going to be the case. It is a fascinating area because it's constantly evolving, as the research comes out, and just like your PhD is going to contribute an enormous amount of data to our knowledge bank, we're constantly learning in this space.
Yeah, so interesting.
Yeah. Now, looking at bacterial vaginosis, it is treated with antibiotics, which are effective for short-term relief. But a 2020 review showed that 25% of women experience a recurrence within 4 weeks, and up to 50% of women experience a recurrence within 3 months. So as a clinician, how can we get better results for our patients? Because, those stats are horrid. They're really so poor. I mean, how can we get better results for our patients?
They are poor. And bacterial vaginosis is it is the most commonly clinical presenting genitourinary infection out of all of them. So thrush is the second, even though most people will talk about thrush or tell you that they've had thrush, but may not be able to identify that they've had BV.
Yeah.
The trick, I think, as clinicians in how we can get better results for our patients is to recognise those statistics and understand that, a once-off occurrence of BV is likely to result in a recurrence. And if they're not treated effectively or consider the whole microbiome and the influences on that microbiome that led them to that outbreak or that issue in the first place, then we're not going to get long-term results. So the key with addressing recurrency in BV is to consider the Lactobacillus situation, because the definition of BV is a loss of Lactobacillus, this, tipping of the seesaw where we have the overgrowth of facultative anaerobes like Gardnerella vaginalis or Adipobium or Prevotella, and this decrease of Lactobacillus or disappearance in some cases as well. And so even though a lot of the research tells us when BV is treated with metronidazole, for example, we see a recovery of Lactobacillus quite quickly, the longer-term research tells us that also doesn't hold for people. And so we need to assess the why. The why did this person end up there? What is in their lifestyle that might be influencing the vaginal microbiome? What sort of hormonal factors could be going on, and addressing as many of those touch points as possible, including partners, because we also know with BV, particularly recurrent BV, that if they have a male or a female partner, those things need to be considered. And when it comes down to male partners, there's actually some really interesting research where you can predict bacterial vaginosis incidence by the penile microbiome of a male partner.
Fascinating.
So there's this translocation thing that's going on between partners. So the restoration of Lactobacillus, or making that vaginal microbiome resilient and robust again post-antibiotic treatment, or if we're looking at recurrency, as a treatment in itself, is really key to breaking the cycle of BV, because it will just keep shifting out. So, for me, that it means that I generally will address sexual interaction and modify that while we can, so that we're limiting that disturbance factor. Anything that will disturb pH, because once we disturb pH, it's also an opportunity for these microbes to increase. So that includes ejaculative sex or lubricants, or if they are douching or irrigating, that may not be the best thing for them at that time. Using soaps, for example, assessing workout gear, underwear. So many things in just lifestyle-orientated stuff can impact recovery. It's not necessarily the only thing, but it's going to make it harder if they keep flipping back into disorder. And then looking at where it occurs, in a cycle, if they have a menstrual cycle, because, again, that helps you understand what microbial shifts could be going on and their relationship to hormones and whether that needs to be addressed for an individual.
And do you think that tracking, generally tracking for 3 months is a good amount of time to see some patterns? Like, it would just be good to have a time frame that we can, give to patients up front of how long we would like them to track their symptoms for to find some patterns.
Generally within a month, you've got a pretty good data set to understand. And in my experience, most people are happy to continue to track ongoing because it's interesting for them. And then they also become empowered because they can see that pH rise above 4.5, which generally is moving into dysbiosis and BV territory.
Yeah.
So they can understand to act as well. If you've given them strategies that they can utilize at home to move things back into range really quickly, then they can do that because they've seen it move out. So it means it doesn't progress because the microbiome just needs to be continuously shifted back, reminded that it needs to be in range. So to prevent this cycle from, occurring, we need to give it time to recover. We need that, endogenous or native lactobacilli to be able to grow back up and to be able to stabilize. And that doesn't happen if you're constantly moving into BV or you're challenging the pH on a regular basis. So tracking is a really useful, cost-effective tool that's empowering for people. And certainly you need to consider nervous system burden because it's not for everyone. But in those people, ideally for pH for the first month, I ask people to do it daily, but not everyone is going to do that. And I don't know if I would because I'm not that sort of person. But ideally, then test when you have symptoms. Test at least, in the follicular, ovulatory, luteal phases at least once if you can. Yeah. If you feel a niggle, have a discharge, notice an odour, test because it's going to give you that pattern so that you understand as well.
And a clinical question, what is the most efficient way for a woman to test her pH balance? How does she actually do it?
You can get different types of litmus pH paper. It needs to be low range, so it needs to cover essentially the ideal pH range for a vagina, which is anywhere from 3.8 to 4.5, but it also needs to go above that. And it needs to be at least 0.5 increments so that you can get those subtle shifts of 0.5 to understand that, because there is a difference between 4.5 and 5 when we're looking at vaginal pH. So if you go from 4 to 5 on your scale, you're going to miss that. And then generally just, either if it's a roll or a strip, there's two different ways I tend to advise people to do it. They can use little cotton tips and do a self-swab and apply that to the paper. Okay. Although that's not always super effective for conditions where there is less discharge or it's a pastier, drier discharge, which tends to fall into that recurrent thrush picture more than anything.
Okay.
Otherwise, they can fold the paper and scoop it around the inside of the vaginal canal and then read the paper from there. And again, that may not be appropriate for people that have vaginismus or if they're highly reactive and highly atopic as well. You need to be really aware of what people's triggers are before you get them to do any of those things. But it can be quite straightforward. For people that have quite significant vaginismus or vulvodynia but are seeing pelvic physiotherapists, I will often just get them to be that's part of that visit to that pelvic physio, that they get their pH done and recorded while they're doing all the other exams.
Yeah, well, some super useful clinical tips there, Moira. Thank you.
Okay.
Now, I'd like to talk about the role of vaginal microbiome testing in clinic. So, what are your thoughts on it? And when is the most appropriate day of the cycle to test?
Yeah, vaginal microbiome testing is a very useful tool for us, particularly in atypical presentations, recurrent presentations that aren't responding to therapy, or if people have been told that everything's normal when it's clearly not.
Yeah.
Then there's a good role for vaginal microbiome testing because we get an insight into microbes that possibly aren't culturable or are not reported upon in standard gram stain culture and microscopy. So it can be useful to understand that, and it can also be useful to understand the vaginal microbiome in both health and disorder. So you get a baseline essentially of what microbes are there, and then by understanding pH fluctuations, you can make some judgments around what could be shifting and changing over the course of a menstrual cycle.
Okay.
Based on what you already know is living within that microbiome. But generally, if we're going to get the most bang for our buck with the vaginal microbiome test, it does relate to what the most appropriate day of the cycle is to test, and that is dependent upon the individual.
Okay.
So for me, I get people to test when they're symptomatic, because that's the shift I want to understand in most people, unless they're coming to me for general maintenance or, for example, fertility, and they're not necessarily symptomatic. Then you would be testing around, when you're trying to conceive.
Okay.
Around ovulation, mid-cycle, or sometimes even just understanding an early cycle. So there's not necessarily a right and wrong, but for people that have recurrent imbalance or infection tendencies, you want to test when they're symptomatic so that you can get a snapshot of what's going on in disorder for them.
Yeah, I think it's a fairly new area in clinical practice, and a lot of practitioners out there may not have started doing this or may be a little unsure. But I think that gives us some really clear clinical guidelines that we want to test our patients when they're symptomatic, especially if they're getting recurrent symptoms. But if they're coming in for generalised support and possibly preconception, then around ovulation is going to be the best time for them to do that microbiome testing.
Yeah, that's what I've worked out so far.
Beautiful. Now, I want to discuss some simple and some practical tips to support both the uterine and the vaginal microbiome. What are some tips that you can share with us?
I think that when we're looking at it from a clinic perspective, or we're talking to clients around it, the best tip is to actually have the discussion, and then to go into a lot of lifestyle stuff. I mean, most people, when they have recurrent issues, will tell you, I've done all the things, I've changed my underwear, I've don't wash with soap, etc. So a lot of that is generally covered, but there is a lot of other things and the nitty-gritty detail that you need to understand so you can help somebody modify and identify what their risks may be. So things like lubricant, for example, and ensuring that your lubricant is pH or osmolar correct, so it's not damaging to the environment or damaging to your cells.
Yeah.
Because a lot of people aren't aware of that. And sometimes even if they are using barrier methods, they may not be aware that some barrier methods have casein in them, and that could be problematic if they have issues with dairy proteins, or if they are atopic, that can also be a problematic factor.
Okay.
So some of those really practical things that are not even involving ingestion therapies or vaginally applied therapies. It's just about what you're doing every day that could be challenging this environment. And I think because we have this higher use now of workout gear, for example, that's an area that probably needs to be explored a little bit more directly as well, because most people will say, I've changed my underwear and it's all natural. But then they're putting themselves into some, semi-recycled plastic bottle lycra pants and, and that's not breathable, and they're in that and they're sweating, and that can be a challenge for them, in different circumstances.
Yeah.
So those sort of things. And then, of course, we need to also be brave enough to ask questions around sexual habits with people.
Yes.
To understand that as well, because there are certainly practices that maybe people are not aware of that they could be doing or not doing that could be challenging the environment. And, we're never going to know about those unless we ask about it. So we have to be aware and certainly encourage people to be more mindful of their genitourinary and sexual health, and even things like STI screening, for example, is something that a lot of people will not have done regularly, or it had, particularly in an older age group, it may not have crossed their mind that that's something that they need to even consider. That once the risk of pregnancy is decreased, sometimes the flag to go and get an STI screen also disappears. So these sort of things are just discussions that we can do to look after the microbiome. I mean, anything essentially that is shifting or changing the environment needs to be screened for, because if you don't change those things, then anything you're doing is not going to necessarily it's going to be harder to get that change you need in that space.
Yeah, there's so many factors there, but some really, really good tips. And I think you're right. In clinical practice, no amount of information is too small, or no question should not be asked. So, sometimes we just have to have those really honest conversations with our patients too, because sometimes they might not want to discuss their sex life with you, but it is important.
Yeah, it is important. And I think there's various ways to approach that. I mean, even So people come to me specifically for help with their genitourinary health. I have a screening questionnaire that also asks a lot of those questions already, so that I understand, where they're at and, what type of partner or partners that they have, etc. So that, we're not sort of limited. I mean, they know I'm going to be asking those sort of questions, and I do always let people know I'm going to be asking you some very personal questions and I do apologise, but the need for me to know means that I can help you. So often even just explaining that, and because it's such new territory for so many people, and that they've not even been brave enough to discuss their vaginal symptoms most of the time, and then you're there asking them about what sort of sex they're having and how many people they're having it with and what type of lubricant they're using and what their hygiene factors are around that. It can be a bit confronting, so you do need to ease into it. But I think that most people appreciate that really frank discussion as well, because they're probably worrying at the back of their mind, is there something that I'm doing? I mean, a lot of people are looking for the factor or blaming themselves, and there are things to be found, but sometimes to find nothing is also confirms some of our diagnostic pathways as well.
Yeah, so I think the pre-frame is a great idea, and explaining to them that, the information that you're asking for could be very helpful in determining what treatment you're going to recommend for them. What about foods that can influence the vaginal microbiome? What foods should we be eating?
Yeah, I mean, when we look at this on a research level, there's not a lot of information. There's certainly links between glycemic load and diets and vaginal microbiome. So, looking at that overall healthy diet. And we do know that even though the vaginal microbiome is an independent microbiome site, it does still interact with the gastrointestinal on some levels. It's not probably to the extent you would think, in that they're not so similar that you can predict one microbe in one space to the other. But their relationship is still linked in terms of anything that you would do to support microbial health for the gastrointestinal system will improve microbial health for the vaginal microbiome. So getting people to clean up their diets and to remove anything that you think might be a problem food or a glycemic trigger is really important. And then sometimes in specific genitourinary disorders, you're looking for, going down rabbit holes and looking at things like oxalates, for example. But it tends to be something that I don't do straight away, because that sort of restriction or elimination diet is a pretty big change. And if it's not necessary, then it's not necessary. So whole food diets are probably my answer to that. And abundant colours and polyphenols and plant fibres and anything really that you would associate with microbial health in other sites.
Yeah, that's very sound advice. And I do like the angle of the glycemic load and just, watching those blood sugar levels as well. Now, you have quite a lot of different roles. You're in clinical practice, you're in research, you're in education. How do you balance those three hats that you wear?
Yeah, it's a really great question. I think that I'm very good at segmenting.
Okay.
And they are all related, obviously, but I'm mindful of what I do on what days. And I'm not in full-time clinical practice because I am in full-time PhD. So I have, set times that I do things, and I'm very mindful as well not to promise things I can't necessarily deliver.
Okay.
So I've gotten much better at that, and I also don't put pressures on myself to, for example, deliver a treatment plan straight away. I have a set amount of hours, or days that you will get this through on this day if you see me on this day, so that I allow myself time to do that. I do, however, make sure that, I do work hard. I get up early in the morning and I will do work in the morning or edit or do some referencing and do those sort of things. So being aware of what tasks I have and just chipping away at them essentially is how I bring it all together. And yeah, there's also, outsourcing what you're not good at and not being afraid to say no and knowing where your boundaries are all really important things as well.
Yeah, and I must say, it takes a few years of clinical practice to work out how to do those, setting boundaries, saying no. So, it takes time to become good at that side of work as well. Now, for those new graduates or practitioners that are looking to build their clinical practice, what's one tip that you would give them to build a successful clinical practice? Because clearly you are very successful, Moira.
Oh, thank you. It took a while, and I think that that's okay. You don't need to know everything straight away. I don't think you ever need to know everything. There's always the internet, and there's always books, and there's always good mentoring that you can access.
Yes.
But I do think you need to be aware that you need to put in effort to be a success at anything. And also that there's a whole lot of mindset and associated with this profession particularly, and what it means to, make money from it or to be successful. And there are lots of different ideas around that, and some of them are not true. Yeah. So you need to be okay and work through those blocks and think about what you really want. I mean, I think at the core of it, we get into this job because we want to help people, and we want to help people heal and travel along their life journey. And I think that that's a really wonderful thing to go into a job for. But we also, as humans, need to survive, and we need to make a living. And if you want to do that in the job that you love, you also need to be okay with that. So there's, I don't know, it took a while to work through that. I remember not being very good at rebooking people or asking for money, for my services. And you have to sort of be okay with those things.
Yeah, you do. You absolutely do, because we want to stay in clinical practice, and that means we have to be able to pay our mortgages, our rent, or whatever it is. We need to be able to do that as well.
Yeah, and there's wonderful things out there now to support us, certainly booking systems and automations and all of those sort of things. That once upon a time, I had a big, huge diary on my desk that I would scribble in and write people's names on, and it was all very manual, and now it's all very automatic, and so I can take myself out of a lot of those uncomfortable situations that maybe previously I was not very good at. So I think that's also a really important part of building practice as well, is identifying which bits make you squeamish and really examining the why of it.
Yeah.
But also being aware that in terms of this particular career or profession or trajectory that you've chosen, that let it evolve, because I certainly don't think I would ever be here. I remember speaking to somebody once, and they told me, "Oh, you'll be in women's health." And I was like, "No, I won't. That's the last area I want to be in." We went through our own, personal fertility journey, etc. And even at the end of that, I didn't want to have a bar.
Yeah.
doing any of it. But this area excited me, and it took a while to find me. So don't feel like you have to niche straight away. But if there is an area that you enjoy, just work away at that. And it doesn't mean that you limit or yourself to not seeing other types of people, because I certainly still have diverse patients, and they're not all female. And things constantly surprise me that end up across my desk. So you're not limiting yourself by deciding you want to sort of work in one area, but you also don't have to just work in one area.
Well, we are all very glad that you are working in that one area and being that person at the front that we can all learn from. So thank you, Moira, for joining us today and taking us through how we can best support the genitourinary microbiome. It's definitely an area that has been somewhat a bit taboo in the past, and so many practitioners don't have a lot of knowledge in this area. So thank you so much for sharing simple, practical and actionable tips with us today.
Oh, it's been my pleasure. Thank you for having me.
Thank you everyone for listening today. Don't forget that you can find all the show notes, transcripts and other resources from today's episode on the FX Medicine website. I'm Emma Sutherland, and thanks for joining us. We'll see you next time. This podcast is intended as healthcare practitioner education only, and it is not a substitute for medical advice, diagnosis, or treatment.